So it's 6 p.m. UK time, so it's time to start our first live event today, and we are starting with an online patient meeting. I'm happy to be back as always. I'm your host, Caroline, and as you know, we have another topic to discuss, and I'm sure you are quite ready to ask your questions and simply get to know some of the answers from Dr. Roksolana Semchyshyn, as she is our presenter today. Hi, Dr. Roksolana. How are you feeling today?
Thanks. Well, I'm very glad to be here with you.
We are happy to have you as well. This is not your first webinar with us. So I'm even more happy that you have decided to come on board with our Stronger Together initiative. And therefore, I just also want to mention that all the events have been brought to you thanks to our ambassadors and partners. You can see all of them right here on the screen. So, and the partners, of course, as well. So thank you to them for their support. And as always, let me simply tell you that our topic is how to get 80% success rate in IVF. So definitely a topic that is interesting. And I'm sure you will have plenty of questions in regards to this. And as I mentioned, Dr. Roksolana is our presenter. So she will start with her first introduction, and then we will go for those most common questions. And of course, after this will be time for your questions. All you need to do is just type those in the chat section so that Dr. Roksolana can simply answer them for you. And let me just mention that, of course, Dr. Roksolana is the head of IVF department at Intersonal Clinic, which is located in Ukraine. And well, just let us know that you can hear us, and of course we will be able to start. Okay, Dr. Roksolana, are you ready to begin?
Yes, I'm ready to begin.
Excellent, so go ahead.
So hello, my dear friends. My name is Roksolana Semchyshyn. I'm fertility specialist. I'm working in the field of IVF for 16 years. And nowadays I'm head of IVF department at Intersonal Clinic. Our clinic is located in Ukraine, in the beautiful city Lviv. This is nearby the Poland, so this is the closest city to the border. Today we will talk about the success rates and how to reach the maximum result for the IVF procedure. And I suppose that this is the first question which the patient asks on the consultation. What is my chances? What are my chances for the pregnancy? What I need to do to higher my chances, and what can influence on my chances? So, Caroline, we can start with our questions.
Excellent. Thank you so much for that. And so let's begin with the very first question. So what can affect success rates in IVF?
So we have the two main factors, even three, but the main factors, this is the embryo. I mean that it's very important, the quality of the embryo, the quantity of the embryos, genetically health of the embryos. Also, the second one point, this is the successful implantation. We need to understand that if we have even genetically healthy, good morphological embryo, we need to have all factors of implantation to have the good success rate in our pregnancy. And the third part, this is clinic. I understand that here we have only very experienced clinic, but still in Ukraine, not of our clinics are so experienced, and not of our clinics have good equipment or good doctors. So first of all, please pay attention to the experience of the clinic, to the experience of the doctors, and to different details, especially if the clinic is open to the patient, if the clinic can show you all the documentation, show you the clinic itself, and can communicate with you, this is the option to choose. So let's start with the second one question.
Perfect. Thank you so much for explaining the very first question. Next one is up right here. Embryo quality, the key role of oocyte and sperm.
So let us start from the first factor. This is embryo. I want to mention that if you have any questions, you can type them during my speech, You can just interrupt me if it is easier for you to give the question during the topic, or you can just start the question and we will return back to it after I will finish all the questions. So embryo quality. We understand that we have also here two main factors which will predict the quality of the embryo. This is the oocyte and this is the sperm. So we will look on the oocyte separately and we will look on the sperm separately. If we will start from the oocyte, so the oocyte, this is the main creator of the embryo. And if we are talking about the oocytes, we also here have two main factors. This is the quality of the oocyte and the quantity of oocytes, which are needed for the best successful rates. So if you are talking about the quality, what factors can influence on the quality of our oocyte? First of all, this is age. We understand that the age for women, this is the crucial factor because our biological clock, we can't stop. It's ticking every day. So every day we are losing our oocytes and we are losing the quality of our oocytes. Why? During the fertilization, oocyte is dividing. And for this division, we need a lot of energy. If the oocyte is young, we have a lot of energy and the division is correct. If the oocyte is aged, we have less energy and we can have the problems with the division. We can have incorrect division and sometimes we receive the embryo which can have chromosomal abnormalities. How age can correlate with our success rate? If we have the age up to 35 years, statistically, out of 10 our oocytes, 7 will be good quality and will divide correctly, and only 3 of them can have some chromosomal abnormalities. If we are talking about 35, 39 years, we call it like a gray zone. This means that we can have chances 50-50. This means that half of the oocytes can have the right division and the second part will have abnormal division. In the age range 41, 42 years, we have 80% of abnormal division and only 20% of normal division. But after the 42 years, we can have catastrophe. This means that only 2% of all our oocytes will divide correctly. But we understand that after 42 years, we have not so high ovarian reserve. And we need approximately 80 oocytes to have 2 embryos of good quality. This is just unreal situation. This is very hard to receive. Therefore, we ask you to think about the maternity in the age up to 35. This is the best option. But in case you are in age 35, 39, please think about your maternity. And if you don't plan nowadays to be the mother, you can have the option to vitrify your oocytes and to have like a backstage for the future maternity. And in age 42 plus, you can use your vitrified oocytes and to have your own genetic children. The second option, which can influence on the quality of the oocyte, this is stimulation protocol. Nowadays, we have 2 stimulation protocols. You know that this is the short protocol, so-called short protocol with antagonists, and the long protocol with agonists. Just yesterday, I went through the new one investigations that shown me the information that indeed there is no specific data which confirms that one protocol is better than another one. So if you are a good responder, you will be a good responder on each protocol. If you're a bad responder, then we understand that the quantity of oocyte is not enough and any protocol for you will not give you the best result, the better result. The main factor in stimulation protocol, this is administration of all medicines, just like a doctor prescribed, because sometimes they understand that for the patient, this is a big stress, because you have simultaneously a huge number of new medicines, and some of them you need to insert intramuscular, some of them you need to be insert subcutaneous, some medicines this is like a tablets. So this is a huge stress for you, but please be very specified in administration of the medicine, because all this can influence on the quality of the oocyte, especially if you will miss the day of administration of the medicine. This can influence crucial to our result. Also, some medicines, stimulation medicines, can increase our oocyte quality. For example, this is LH stimulating medicines. They are beneficial for the patients in age after 35 years. If we are adding LH supplementation to the protocol of stimulation, those patients can benefit in the quality of the oocytes. Also, if we are talking about the triggering, HCG triggering gives us a better result. We can have more mature oocytes, and the results will be better. Also, on the quality of our oocytes can influence the timing of triggering. This is very important to insert the trigger exactly at that time which is prescribed in your protocol, because if you will miss the trigger or you will postpone it, it can influence on the quality of oocytes. Sometimes very rare, but still our patients are missing the day or missing the time of the triggering. In that case, we can have not mature oocytes or even preterm rupture of the follicles, and we cannot receive the oocytes on the egg collection. If we are talking about the quality, the first question is for sure, what number of oocytes is adequate for our best success rate. So 12 oocytes, this is the optimal number of oocytes which will provide us at least 2 embryo of good quality. But if we are talking about the age, we can have morphologically good quality. This means that when the embryologist is looking on the embryo, they look good, but still they can have inside chromosomal abnormalities. We can't see them without special investigations, without special testing. This testing is called PGS. And sometimes we understand that our negative attempts in a patient in the age after 42, even with a good quality embryo, means that the embryo was with chromosomal abnormalities. So how can we influence on the quantity of the oocyte, or what can affect the quality of the oocyte? First of all, this is IMH level. IMH level, this is our predictor of quantity of the oocytes that we will receive, and antral follicle count. Before you will start the stimulation, the doctor will monitor your antral follicle count and monitor your IMH level. And the higher IMH level you have, the higher number of oocytes we will receive on the egg collection. Especially, of course, we understand that IMH, this is the marker of oocyte, of ovarian reserve, and IMH level is decreasing with the age. So the age, this is factor not only the quality of the oocyte, but also a quantity of the oocyte. Because at the age after 40, we have extremely decreased levels of our AMH and our ovarian reserve. Also, on the quantity of the oocytes can influence the starting dosage of stimulation. If we will start with a maximum dose of stimulation protocol, we will receive the higher quantity of the oocyte. If we will start from minimum dosage of the stimulation protocol, we cannot receive the maximum that we can out of our ovaries. Also, the technique during the aspiration can influence on the results. because during the aspirations, we need to aspirate all fluids out of the follicle. Sometimes the follicles are hard to reach, and the doctor can miss the follicle or can just can't reach the follicle. This is also the parameter which can influence on the quantity of the oocytes. Also, in our clinic, we are using the flushing of the follicles, especially when we have less than 6 follicles. This means that sometimes the oocyte can be fixed to the wall of the follicle. And if you are just aspirating the fluid out of the follicle, the oocyte can be left in the follicle. Therefore, we're using the flushing. We insert inside the follicle the liquid, which just flushes the follicle, and then we will once again aspirate the liquid. And during this flushing, we maximize our chances to receive all oocytes that are in your ovaries. What to do if you have a few follicles or a few oocytes and decreased levels of IMH? How to increase our chances? In our clinic, we use so-called embryo banking. This means, for example, if you have during the aspirations 2 or 3 oocytes, your chances for the good blastulation is approximately 40%. So out of 3 oocytes, we cannot receive the blastocyst. But if you will fertilize those 3 oocytes and freeze them on the zygote stage, this means that you will freeze the embryo on the first day of their living, then repeat the stimulation, again receive several oocytes, fertilize them, and cumulate several embryos, for example, at least 6, you will increase your chances to a normal responder. And you can use your own oocytes, and you can increase your chances for a better success rate. Also, sometimes if we have the poor quality of the oocytes, we can use the solutions for the cultivation, which are rich with additional ingredients for the better cultivation outcomes. For example, if we have the patients who have poor blastulation rates, for example, out of 8 zygotes, we have no blastocyst. Then for the next stimulation protocol, we analyze with the patients our future steps. We can change the protocol, we can change the stimulation method, and also we propose for the patient additional cultivation systems, solutions, just to give rich ingredients for the better cultivation for the patients. This was all about oocytes. Also, the second creator of the embryo, this is the sperm. And let's talk about the sperm factor. If you are talking about the sperm, at first, the most important thing for the spermatozoa, this is the morphology of the spermatozoa. If you have the good morphology of the spermatozoa, we will have the good quality of the embryo. And what to do if the morphology is bad? First of all our patients are undergoing the consultation of urologist, and urologist is working with the patient and preparing for the IVF procedure. We understand that for the IVF procedure, we need only 10 or 11 spermatozoa, or maximum 20, 25. It depends on the quantity of the oocyte, but still we need them with a good morphology. And the urologist is working hardly to receive the good morphology of the sperm. Sometimes we have the patients who even after this treatment, they do not improve the results of the morphology. What to do in that cases? We started to do the TESA procedure. This means that we are extracting the sperms out of testes. And in case that in ejaculate we don't have morphological normal spermatozoas, or we don't have any movement or active movement of spermatozoa, In that case, we are proposing for our patients extracting spermatozoa from the testes, and this can increase our chances to receive the better quality of the sperm. Also, we can use the PIXI or IMSI method of fertilization. This means that we are selecting the best spermatozoa based on morphological criteria and doing the ICSI procedure for the oocytes. This can increase our chances for the pregnancy. What about questions? Do we answer now for the questions, or we will wait to the end? Carolina,
yes, we can go ahead with those most common questions, and then we will go for the patient's questions right after. Okay?
Okay.
Perfect. Thank you so much for explaining all the details to this question. Lots of useful information indeed. And now let's have a look at the next one. So does egg donation increase our chances for success?
Yes, egg donation increase our chances for success in case you have a low AMH level and you have no oocytes at all. In that case, we can increase our chances for the pregnancy with egg donation programs. Or you can have a combined IVF program. What's this? For example, we receive only 2 or 3 your own oocytes, and we understand that your chances for the pregnancy are from 4 up to 10%. But we want to have higher percentage rate. We can propose you combined program. This means that you can add to your own oocytes a few more vitrified egg donation oocytes. This is a good option because the vitrified oocytes, they are always available. We have no waiting list for them. They are all genetic tested, so our donors are all fully screened for all genetic diseases that are most common. And all donors are with a proven fertility. This means that they have already their own babies, so that their eggs are good enough. And we have more than 450 different profiles with the different phenotypes. We have anonymous and non-anonymous donation, so you can choose your donor into addition to your own oocytes. We will cultivate them separately. Your oocyte you will know where are the baby out of your oocyte or the baby is out of donor material. And then we can receive the result. If you have no blastocyst on your own oocyte, you will have the blastocyst for sure on egg donor oocyte. So this will gives you like a backstage, and you will not miss the cycle. You will not miss the embryo transfer, and you will achieve pregnancy with a higher percentage rate. Also, if you have advanced age, this means that if you are 42 years plus, you have very high chances of chromosomal abnormalities in the baby. So either you are doing PGS screening, but we need to understand that we can test 3 embryos and all of them can be with chromosomal abnormalities. So if you have the patients in age after 45, 46 years, where we understand that almost all oocytes are with the genetic diseases, in that case, of course, egg donation, this is the best option for you to have the maximum chances for the pregnancy. And of course, we can look on egg donation when we have poor outcomes in the previous stimulations. For example, you had 2 or 3 your own stimulations and you didn't reach embryo transfer ever. This means that you have some problems with the oocytes, and they can be not in the field of genetic problems, but this is the quality of the oocyte. And this is the situation when we can benefit from the egg donation program, especially from the vitrified oocytes.
And again, thank you so much for answering that question. And there's another one right here. PGS screening for whom and when?
PGS screening, this is the screening of the embryos before the embryo transfer for the genetic diseases. PGS, this is screening. This is diagnostic for chromosomal abnormalities. We know that we all have 46 pairs of chromosomes, and they have some morphology, they have some characteristics, how they need to look like. And we are testing the embryo for the number of the chromosomes and different aberrations in that chromosomes. And also we can have the option of PGD. This means that we can diagnose some specific genetic disease. This is the deeper investigation of the embryo. So for whom we can recommend the PGS, the screening of the embryo? First of all, this is advanced maternal age. We understand that after 42 years, as I've said previously, we have very high chances for genetic diseases and abnormal division. So this is the best option to test the embryo for the chromosomal abnormalities and transfer chromosomal normal embryo. The second option, this is the chromosomal abnormalities in your karyotyping. If you have already in your karyotypes, in your genetic material, some disorders, this means that you will give these disorders to your baby. And in most cases, the embryos will have the same disorders, and we will have no or only 10 up to 15% of normal embryos. So we need to understand which one embryo is healthy and then transfer only healthy embryo. Therefore, if you have some chromosomal disorders in your karyotyping or husband karyotyping, this is the indication for PGS screening. If you have severe male factor, especially if you have cryptozoospermia, this means that we have less than 1 million sperms in the ejaculate. Or especially if we have disorders in the male chromosome, especially deletions. This means that we need to test the embryos, because in case we have the deletions in Y chromosome, in that case, if you will have the boy, it will be transmitted to the son. Therefore, we need to choose just the male woman and the sex woman, and we will have the higher success rate for our pregnancy. Also, in case that you have numerous miscarriages, this also can be because of genetic disorders of the embryo. And this is also the indication for you to do the PGS screening and to understand that we are transferring the healthy embryo. And also we can use the option of PGS screening for all patients who just want to be sure that we are transferring the healthy embryo to the uterus, and we will have the best options for the implantation. We understand that if you will have the genetically healthy embryo, our chances for the pregnancy are around 80%. Therefore, PGS screening, this is a good option, maybe not to increase the chances, but to exclude the negative attempts, because we understand that the genetic health of the embryo, this is the main factor and the key role of our success rates. When to do? First of all, this testing should be discussed in advance. The doctor should explain you what are the advantages of this testing, explain the benefits of this testing, and afterwards you can make your decision to do or not to do. Sometimes this is the indication as the advanced maternal age. Sometimes this is a willing of the patient. For example, we had in Ukraine, this is allowed to do the sex selection. I know that in most countries this is forbidden because this is not right from the ethic point of view. But in Ukraine, this is legal. So you can choose the sex of the baby. And we have the patients who have, for example, 2 or 3 sons, and they very want to have a daughter. So they are undergoing the PGS screening for sex selection just to have the daughter. And this is the option to discuss with the doctor, to ask maybe the doctor the questions, do I benefit from this? If yes, then for sure you have to do it. If not, then this is you're willing to do or not to do. Thank you, Caroline. The next.
Thank you so much again for explaining this particular question. And next one is here. So implantation. So what is important about this?
When we are talking about the implantation, we need to remember several key factors. First of all, this is endometrium. Then this is the uterus. And then this is the special window of implantation. I will further describe what this. We need to take into account our hormones, the level of the hormones, our immune system, and our coagulation system. So let's start from the endometrium. If you're talking about the endometrium, so we need to detect the thickness of endometrium, the structure of endometrium, and the presence or absence of inclusions, for example, polyps or synechia or something like that. If you are talking about the thickness of endometrium, the best option, this is from 7 up to 13. If you have very thin endometrium, this is not good. And if you have very thick endometrium, this is also not good. Why? If our endometrium is very thin, this means that it can be estrogen resistant. This means that endometrium doesn't have a good structure and doesn't have enough power to implant the baby. Also, if you have thin endometrium, we have decreased blood flow. This means that baby, when we'll implant, it will not have enough blood to grow, and also we can have the miscarriage or the failure of implantation. And also, if you have a thin endometrium, it can be after the injury of basal layer of endometrium. For example, after the abortion or after the hysteroscopy, when we remove the endometrium out of the cavity. So this is the iatrogenic problem, and this is the most hardest problem to solve. What can we do if you have thin endometrium? First of all, we can increase the dosage of estrogen. For example, if you are undergoing your stimulation, you have enough quantity of the estrogens because the follicles, they grow and they produce the estrogens, and we have good enough levels of estrogens to support endometrium. But if you are in a cryocycle, for example, you are undergoing the egg donation program and you don't have the stimulation, you don't have the increasement of your own estrogens, then the doctor is prescribing you external estrogens. And if you have the thin endometrium, we can increase the dosage of estrogen. This is the simplest way to increase the thickness. But as I've mentioned, we can have estrogen-resistant endometrium. What to do in that case? In our clinic, we practice 2 methods. First, this is the synthetic growth factor. We are inputting growth factor inside the cavity, and we are flashing the endometrium inside the cavity. This means that we are stimulating by the growth factor, the endometrium cells to grow, and we have a good results on it. We are doing this procedure in the cycle of embryo transfer, approximately on day 10 up to 12-13 before the embryo transfer. So this is enough time to react after the growth factor, and we see that in most cases we receive at least 7 millimeters of endometrium on the embryo transfer. Sometimes we don't have the result of synthetic growth factor, and we are using our natural growth factor. This procedure is called PRP. This is we are inputting the plasma which is reached by platelets. So this is your own blood, which we centrifugate, and we receive the extract of platelets, and they contain the growth factor. And we are inputting that plasma, your plasma, inside the cavity. And this is a natural way to input the growth factor inside the uterus, and we also receive the good results on it. And we see that even in case when the synthetic factor doesn't work, our natural factor works. In case we have thick endometrium, this is easier. This means that we have hyperplasia. This means that this is also not a good structure for providing the implantation for the embryo. So we need to remove that endometrium and to give the best chances for the embryo to implant into the normal structure of endometrium. What about the structure? The structure is also very important. We are using ultrasound scanning to detect the structure, and the good structure, this is triple lining endometrium on the ultrasound scanning on day 8 up to 12. Also on ultrasound scanning, we are looking for the includings for the polyps. Polyp, this is including inside the uterus of, this is the includings in endometrium, which lower our chances for the pregnancy. So if we see on the ultrasound scanning some includings in the cavities, we need to remove it. So we propose to do the hysteroscopy for that patient, and we are removing the polyps from the cavity. What about uterus? So when we are discovering the uterus, first of all, we are taking into account myomas, and we are looking for the septas or some abnormalities of the uterus. If we have myomas, depending of the size of myomas, and depending on the layout of myomas, we are choosing the tactic. For example, if I have the submucosal myoma, we need to remove it. If myoma is less than 3.5 centimeters, we don't touch it. So you can be pregnant, and this size of myoma doesn't influence on the pregnancy and outcomes. What about septus? If you have the septus inside the uterus, this is indication for the removal of that septus. We propose to do the hysteroscopy and to remove the septus, because this septus will influence not on the your chances to be pregnant, but the chances of carrying out the pregnancy. The investigations show that the patients who have the septus, they have higher percentages of miscarriages in a comparison with the patient who didn't have the septus inside the uterus. So we recommend for sure to remove the septa out of the uterus. If we have abnormalities, for example, bicornus uterus, this is the situation when we can't do anything. So this is just the option to do IVF, and that's all. And how to differentiate if this is the septal uterus or bicornus? The best way, this is 3D ultrasound scanning, when we can show where we can see the uterus in the 3D measurement, and to understand if we have only the septa and we can remove it, or this is the abnormal uterus and we just can't do anything with that. The third option, this is the window of implantation. Window of implantation, this is the time frame when endometrium is the most receptive for blastocyst implantation. As usual, this is 5-6 days after the ovulation. And this time frame continues approximately 24 up to 48 hours. This means that 6 days after the ovulation, during 24 up to 48 hours, our endometrium is most receptive to implant the baby. Therefore, traditionally, we do our embryo transfers on the day 6 or after the egg collection, because mostly, approximately 95% of our patients, they have that window of implantation exactly on that day. But we have also 15 up to 20% of the patients with a postponed window of implantation. This means that that window is closed when we are doing the embryo transfer. And in that case, we will have the failure of implantation and our pregnancy, and we will not achieve the pregnancy. How to maybe further, I will describe the testing, how to detect the window of implantation and what to do if the window is postponed. So the next one option, which is very important for implantation, this is our hormone system, especially the prolactin level and the TSH level. So these two hormones are very, very important for the successful pregnancy. If you have the higher prolactin, we need to decrease it for sure. And if you have the TSH level higher than normal, we also need to decrease it. In case we have higher prolactin levels or TSH level, we will have higher chances for miscarriages or even the failure of implantation. And the last but not the least point, this is the immune system. Immune system, this is the immune system plays the key role in our implantation. Why? Because the embryo, this is something, this is the stranger who drops into our organism. So the immune system needs to defend our organism from that stranger, and our organism need to hide the embryo from our immune system. So this is very, very not easy dialogue between immune system and our organism. Therefore, we are detecting the condition of our immune system before the IVF program, just to understand if our immune system is aggressive or not. Because if our immune system is aggressive, it will not take our baby and it will just kill it or make the all conditions for the miscarriage. So when we are talking about the immune system, we are monitoring, first of all, this is NK cells, so-called natural killer cells, and these cells are responsible for our immune response of our immune system and for aggressivity of our immune system. If we have the higher NK cells, then our immune system is very aggressive. Also, we are taking into account our thyroid glands, not only the TSH level, but antibodies to the peroxyperoxidase and thyroglobulin. These are two markers of autoimmune thyroiditis, and this is also for us not good option, and we need to correct immune system in that case. And now we will discuss the testings, which are on the first line and which are on the second line.
Yes, so the first line testing before IVF, and of course, what to check if the first attempt was negative, the second line testing before IVF.
If you are talking about the first line testing, we have two kind of testing. The first one, these are testing of our general health. As the pregnancy, this is 9 long months, so we need to understand that our body is ready for the pregnancy. So we need to check our body and to understand that all mechanisms and all systems are working good. So we start from GP consultation, that we have no contraindications for our pregnancy. We start from a gynecologist consultation, that we have a normal swamps, vaginal swamp, and we have normal pap tests, so that we have no infections, and that we are ready for the pregnancy. And also very important are hormonal investigations. This means that we are testing prolactin, as I've said, thyroid gland, this is TSH level, and also we are testing IMH level, because this is the crucial marker of starting dose and choosing of the protocol for stimulation. And also we need to check FSH level and LH level. And as I've said, we are checking the immune system in the first line testing. Why? Because we understand that immune system can be aggressive in more than 30% of our patients. And if we will correct our immune system, we will higher our chances for the pregnancy. It is easier and cheaper to prevent or to correct our immune system rather than have the second attempt of IVF. This is from the women's side. And if you are talking about the husband side, then we are testing the spermogram for sure, especially the morphology and the activity of the sperm, total motile count. And also we are testing the husband for DNA fragmentation. This is the testing for the percentage of broken DNA inside the spermatozoa. If we have the higher percentage than 20-30%, this is not good, and we need to lower it, because if you have the higher percent of DNA fragmentation, it can lead to miscarriages or even implantation failure. So this is important for us before the first attempt of IVF. And if we did all this, made the first attempt and we are negative, what to do? So we have the second line testing if we are negative. If we have negative attempt, we need to understand if the reason is in embryo. For example, we had a bad quality embryo, but good quality uterus, and we understand that we need to work with the quality of the embryo. Or the reason can be in uterus. Sometimes the reason is in uterus and in embryo. So if you are talking about the embryo, how to check the embryo, we can have two options. This is karyotyping of yours. We need to understand that your genetic material is healthy. After first negative attempt, we are recommending for our patients to do karyotyping. And if the karyotypes are normal, then according to your age, we have, for example, if you are up to 35 years, so 70% of your embryos have to be healthy. If you are in age 35, 39 years, this is 50-50. If you are after 40 years, we have 20% and less. So in case of advanced maternal age, we recommend PGS, just to exclude that the embryo is not healthy. This is the part of the embryo. If we are talking about the uterus, then we start from hysteroscopy. Investigations show us that hysteroscopy before the first IVF, when we have no indications, gives us no benefits. This means that we have no statistically higher results of IVF outcomes in patients who did hysteroscopy without indications. But in case we have negative attempt or we have indications, hysteroscopy for sure increases our chances for the success rate. What can we do during the hysteroscopy? First of all, we can look on our endometrium. Sorry. Do we have any suspicion zona in the endometrium? We can do the biopsy of that zona. We can also test endometrium for the chronic diseases, for example, chronic endometritis. And this is chronic inflammatory process inside the uterus. And we also can check the level of NK cells inside the uterus, because we know that sometimes we are testing the NK cells in our peripheric blood, but we understand that sometimes NK cells, the quantity and the activity of NK cells in our blood is not corresponding to the activity inside the uterus. Therefore, we need the best option is to check NK cells inside the uterus. Also, in the second line, this is HLA typing. Sorry, what this means? This is the testing to detect your compatibility between the husband. We are comparing your genes and the husband genes. You need to be different in that main genes. Why? Because if you are very similar in the genes, we can have similar mistakes in that genes. In our nature is not protecting that babies, it's just killing it. What to do if we have very high HLA compatibility? We can use the medicines just to correct our immune system. And the last testing in the second line, this is the checking of window of implantation. As I've said you that window of implantation, this is the period when endometrium is most receptive to take the baby. And sometimes approximately from 15 up to 20% of patients, this window is postponed. So how we detect it? We have nowadays very beautiful testing, which is called ERA test. And this testing allows us to understand if the endometrium is receptive or not. How we can do this testing? The patient is prepared as for the embryo transfer, but we don't do embryo transfer. In that day of embryo transfer, we are taking the biopsy, the material out of the uterus for the testing. And we test the endometrium for the receptivity. And we can have 3 options. The endometrium is receptive, so we can use that day for the embryo transfer. The endometrium is pre-receptive. This means that endometrium is not ready now for the embryo transfer, and we need to postpone the embryo transfer for several days. And endometrium is post-receptive. This means that already the window is closed and we missed it. So we need to do the embryo transfer earlier. This is the good option because we did the investigations for our patients in group. We included the patients in that group who had 3 and 2 and more negative attempts, and they have 0 pregnancies in that group. So those were the patients with 0 pregnancies, 2 and more negative attempts. We did ERA testing for them, and in 80% of cases, we had changes in that window of implantation. And afterwards, when we did the window of implantation, we proposed them individualization of the embryo transfer. This means that we did the embryo transfer exact in that day in which the endometrium is the most receptive for the embryo transfer. And we received 68% of pregnancies in the group where the pregnancies were 0. So this is the great result. And I widely recommend this testing for the patients who have 2 or more negative results as the main testing to exclude the problems with the window of implantation. So what to do if you have some disorders in that testing? For example, if you have the disorders in karyotyping, we can do the PGS for screening for the embryo and to detect the healthy embryo. If we have very severe disorders in the karyotyping, then we need to change the gametes. So we need to use donation, sperm donation or egg donation, depending on the changes in the karyotyping. If you have, for example, during the hysteroscopy, we can see the polyp, we can just remove the polyp during the hysteroscopy. If we did biopsy and we have, for example, chronic inflammatory disease inside the uterus, we can use antibacterial treatment and to correct that inflammatory process. If we have immune system disorders, this means if you have very aggressive immune system, we in our clinic use intravenous immunoglobulins to correct our immune system. And we also have good results. We have definitely higher percentage rates, success rates in the patients with autoimmune thyroiditis and in the patients with aggressive immune system when we use during the embryo transfer intravenous immunoglobulins. So let us resume. First of all, I want to ask you, don't miss the time. If you decide to be a mother, just do it and don't miss your time. Second option, this is choose your clinic. You need to look on the experience of the clinic, of the doctor, and just believe it. You need to follow all recommendations of your doctor because it's very important. You need to do all the testing that doctor prescribed and take all medicines strongly as the doctor prescribed. And the last but not the least, I think this is the main point, that you need to believe in your success. Only in case you believe in your success, you will be pregnant. Thank you for your attention, and I'm open for a Q&A session.
Excellent. Thank you, Dr. Roksolana. It has been excellent to find out so many details you have provided to us. So thank you already for this. And yes, this is time for our Q&A session. As you can see, there are plenty of questions ready. Well, let's get to them, okay? The first question is, so what is the success rate for combined program? Is it possible with fresh donor eggs?
The success rates of combined program depends on your oocyte, on your age. For example, if you are talking only about the egg donation program itself without your oocytes, the success rate of egg donation program is approximately 65-67%. This is vitrified or fresh egg donation. If we are combining the eggs, it depending from the embryo. If you will receive the embryo from your oocyte and you are young, up to 35 years, you have 65-70% of success rate. But in case you are in advanced maternal age after 42 and we will receive the blastocyst out of your oocyte, for sure we will have decreased success rates if you will choose the option to transfer your own oocyte. In case you are choosing the vitrified oocytes, you have the best option. This is 65-67, even more if you have no problems with your uterus.
And excellent. Thank you so much for your question and your answer to this as well. Next question, is there an average number of frozen embryos transfers women complete before they see success?
Of complete. Sorry, Caroline, can you hear me?
Yes, I can hear you now. For a second, we didn't, I believe, but now it's okay.
Yeah, that's okay.
Yeah, perfect.
If you are talking about the cryocycles in our clinic, the average rate, this is 63-65 with your own eggs. This means that you need you will be pregnant from the first attempt in 73, even 60-65%. So out of 100 women who underwent our frozen cycle in our clinic with your own eggs, 67, from 60 to 67 will be pregnant. So this is 1.5 embryos to be pregnant from the first attempt.
Okay, excellent. Thank you for that. And there is actually another question in regards to this. So, is it possible to get 80% success rate in the first IVF, or is it more often to have to do more than once? I am 32, he is 43.
It is possible to get 80% success rate in the first IVF when? If you are young. So 32 years, this is the young age. If you have tubal factor, this means that you have a good reserve, you have the good quality of the oocytes, you have the good uterus, but your tubes are blocked. This is the ideal situation for the doctor, fertility specialist, and this is the ideal situation for the patient. This is 80% for sure. About the husband, the age is not so crucial for the husband and doesn't influence on the genetic material of the sperm in such severe variants. Maybe after 50 years, sometimes we can observe some decreasing of the quality of the spermatozoa, but not at the age of 43 years. So 43 years, this is the young age for the husband. In your case, if you are young, if you have good results of your ovarian reserve, you have no polyps, you have good uterus, you have no abnormalities of your uterus, only tubes, yes, of course, you have 80% of success.
And excellent. Thank you so much once again for your question and your answer to this. And next question is up. Is there any evidence for coenzyme Q10 supplements? If there is, how this improves the quality? Does this improve the quality of number of oocytes?
The good question, because every conference for fertility specialists, they have session controversies in reproductive medicines. This means that we have one topic yes and one topic contra. About coenzyme Q10, we have no evidence-based investigation nowadays, which can show that we have some influence on the success rates. Yes, there are some investigations that show us that maybe due to that point, that coenzyme, this is the energy which we give to the oocyte when the oocyte is of advanced maternal age and we have lack of that energy. But we don't know if it works. We have no evidence-based investigations on that, and we are not sure. We understand that this is not harmful and we will not do worse in that case. So if you will take it, at least it will not harm you. For sure, it doesn't influence on the number of oocytes. If it can somehow influence on the quality, it doesn't influence on the number. And please remember that the life of the oocyte starts 120 days at least before the stimulation. So when we are undergoing the IVF treatment, we stimulate the oocytes, which start their which started to grow approximately 120 days before. So if you want to use any supplementations to increase quality, quantity, or whatever, you need to start it at least 120 days before your IVF treatment.
And excellent. Again, thank you so much for answering another question. And here's the next one. Is an AMH level of 1.59 a good level to work with in a woman of 36? How many oocytes on average can get collected based on the before mentioned information?
1.5, even 1.6, this is the average level to work. This is not good and this is not bad. We, at the age of 36, we expect up to 10 oocytes, 8-10 oocytes to receive. If you will have the good quality of the oocytes, in that case, this is enough material to work with. So we expect at least 2 blastoses for embryo transfer, and hopefully you will be pregnant for the first time.
Once again, thank you so much for answering that question. Next one is ready here. I had my 3 IVF cycles at 41. I produced 21, 21, and 31 oocytes. Most immature. My consultant uses buserelin as my trigger. Would HCG be a better trigger?
A good question. Your doctor used buserelin as a trigger because he or she tried to avoid hyperstimulation syndrome in your case. In our clinic, we also use agonists like a triggering in case we have more than 20 follicles to avoid the OHSS syndrome. Yes, I understand that HCG maybe in your case will be better. At least we can use combined triggering. This means that we can use a little bit of HCG plus agonist for triggering. In that case, when we have immature oocytes, we sometimes use combined triggering. But you need to be ready that you can have the hyperstimulation syndrome and you need to be treated from it, and you need to do some preventional things, for example, to avoid embryo transfer, just to and to be under supervision of the doctor, just to avoid of severe hyperstimulation syndrome. Also, I don't know on which size of the follicles the doctor did aspiration. The best option is to do a collection on the size, to do triggering on the size 20-21 millimeters. Literature says from 18 up to 20, but I saw one investigation which shows that the best option is when we have the volume of the follicle 2 millimeters. This means that it is exactly 20 millimeters in size. Maybe sometimes we can see that immature oocytes we receive when the trigger was prescribed a little bit earlier, for example, on a size of 18 millimeters, and maybe you need just 1 or 2 days more of stimulation to have mature oocytes.
All right, excellent. Once again, thank you so much for answering that question. Now we will go to the next question, which is a bit longer. So let me show you. I'm 40, AMH 4.2, PMO, low ovarian reserve. We also have male factor issues, so we use ICSI. Going to try 4th cycle in August. We use this time to get our bodies healthy and healthy sperm. We are thinking of batch cycling, 3 cycles, and then do frozen transfer. Only in last cycle we got to day 5 transfer, but no implantation. This was farthest we got. I know my age is against us, but do you think we should do high dose of menopur or mild?
I don't know which dose of menopur was selected for you. We don't use the pure menopur for stimulation. We always combine the recombinant follicular stimulation hormones with the menopausal. Why? Because recombinant stimulation preparates, they are stronger. Okay, they are stronger, and we have better results on recombinant plus urine stimulation protocols, or we have even recombinant medicines, LH plus FSH. So investigation shows that there is no benefit from the dosage more than 300 units. If you will increase to 4.5, if you will increase to 500, if you will increase to 600, you will receive the same result, because result is depending on the quantity of the follicles. If you have only 2 or 3 or 4 follicles, it's enough for them to grow on that dose that you had. It makes no sense to make a higher dosage because you won't recruit more follicles that you have. In your case, the banking, this is the best option for you when you undergo several cycles just to accumulate the embryos, but we propose to accumulate on the zygote stage, and then to cultivate them all together up to day 5 and do the embryo transfer. You had one negative implantation. So for me, it will be important to investigate also the uterus. If you have all factors all factors that will lead us to successful implantation, that you had a hysteroscopy, that you checked your immune system, that you checked all your hormones, only after that we can understand that your uterus is ready for the second attempt.
And thank you so much once again for answering this question and, of course, providing all the details to our patient. Next question is up here. What is the best way of taking progesterone for a mock cycle, oral or vaginal?
We are using vaginal way as the key way, because vaginal way, this is the straight way to the uterus. So this is the best option. I understand that for the patient, this is not so comfortable because we have discharges on that vaginal way of inputting, but still we prefer vaginal way of inputting the progesterone.
And thank you for that clarification to this question. And let's get to this question. You mentioned adding LH to the cycle to help mature the oocytes. Is menopause an LH?
I mentioned that adding LH help us to to increase the quality of the oocyte. The patient who are after 35 of advanced maternal age, who have the low IMH level, they can benefit from LH adding to increase the quality of the oocyte. For the maturation of the oocyte is responsible HCG. So if you want to receive the mature oocyte, so we use the triggering, and this is HCG preferable for the maturation.
And excellent. Thank you so much for that once again. Okay, next question. What are your thoughts on the administration of monopore for men in order to increase sperm count? Do you think it can negatively affect the quality of sperm, therefore leading to fewer embryos or poor quality embryos?
This is my main rule, not to treat the men, because we have andrologist. This is the specialist who is working with the men. Because if gynecologist will treat the men, this is not good. So I don't use menopur at all for men. I'm working only with the women. But I know that it's very tricky thing to do the stimulation for men. This is we can do harm, and we need the doctor need be experienced, has to be experienced in the usage of gonadotropins for the stimulation in men, because sometimes when we have some correlation of the hormones, we can do even the castration by administration of menopur for men. We can just stop spermatogenesis by using that medicine.
All right. Okay, thank you so much again for that then. And next question from the patient from previous one, actually. Do you think after embryo transfer, when you need to take progesterone suppositories, does it matter if used vaginally or rectal? Really? Yeah, sorry. As the nurse told me to choose myself, it doesn't matter.
We use vaginal way. Why? First of all, this is the straight way to the uterus, because the column of the uterus has the way out to the vagina. So if you are inputting the progesterone inside the vagina, it is closer to the uterus. The second one option, this is the vagina has a lot of vessels, and absorption from the vagina is very quick and effective because we have a lot of vessels inside. We don't practice rectal administration of progesterone because, as for me, I don't know how this is for the patient, this is not very comfortable to use any rectal suppositories at all. But it doesn't have any medical point of view. This is only like a feeling of the patient.
All right. Okay, thank you so much for clarification. Okay, next question is, so if karyotype is normal, is PGS testing not really needed?
If karyotype is normal and if you're up to 35 years old, PGS testing is not really needed, yes. But in case you are of a advanced maternal age, this means after 40 years, even in case karyotype is normal, you need to have PGS screening to be sure that healthy embryo will be transferred to uterus.
And excellent. Thank you so much once again for that. Okay, next question. So what is the risk of damage to the embryo for PGS testing? And there's actually another one from the patient. Can PGS damage an embryo?
We are talking about the high experience clinics with a high experienced embryologist. In that case, this procedure can't damage the embryo because we are taking diffuse cells out of trophectoderma. So the embryo has two parts. It has trophectoderma. This is the outernal part of the embryo, and this from trophectoderma will start placenta growing. And we have inner cell mass. This is cells from which will start the embryo. So we are taking only few cells of trophectoderma, and this is not harmful procedure for the embryo at all. But after the PGS testing, we are cryopreserving the embryo. And we can have the problem with thawing of the embryos, because the percentage of thawing after cryoconservation is approximately from 96 up to 98. This means then out of 100 cryopreserved embryos, 98 will undergo the procedure of thawing, but still from 2 to 4 embryos will die. So if we have 10 embryos for PGS screening, this means that out of 10, with 9 embryos, everything will be good. But if we have only 2 embryos, so this is 50-50. But in most cases, I need to clarify that we are talking about the highly experienced embryology.
Excellent. Thank you again for answering that question. All right. Next question is ready as well. So does having a corpus luteum mean there is a cyst there? What should be done to get rid of it? Is it birth control pills? If so, for how long? Do vitamins, prenatal vitamins, vitamins D, folic acid help?
So corpus luteus is the normal structure of the ovary. When the follicle ruptures, in the place of follicle forms the corpus luteum. So this is the normal structure. This is not the cyst. Sometimes we can see that inside that corpus luteum is a liquid. In that case, we understand that this is the cyst inside the corpus luteum. What we need to do? Nothing. We need just to wait, because in 90-80% of cases, our cysts are disappearing by themselves within 1 month. If you see that your cyst is big or doesn't decrease or persist for 2 or 3 cycles, then of course you can have birth control pills. Give me just 1 second. Okay, sorry for that. I lied. So, how work our birth control pills? If we have the cyst, why we receive the cyst? Because follicle need to rupture, and sometimes when it doesn't rupture, it starts to grow, and out of follicle makes the cyst. So the cyst produces estrogens, and this is like a circle. Cyst is growing out of estrogens because of estrogens, and the cyst is producing estrogens. So the cyst is feeding itself. When we're using the contraceptive pills, we are just decreasing the level of estrogens, and this is just doesn't grow anymore. But in most cases, you don't need to take anything, and the cyst will just disappear by itself in a month, maximum 2.
Okay, just wanted to show you that this is additional information the patient provided from the very same question, of course. Yeah. But thank you already for this question as well as your help with it. Okay. Next question is also ready. You mentioned you need to do you mentioned you do sperm DNA fragmentations as a first line if there is a high level of fragmentation. What can you do to fix it? Our clinic said not necessary to check DNA fragmentation for my husband, but I want to push for this before we do our 4th ICSI cycle.
In Ukraine, we don't have any insurances, and the patients, they pay themselves for the procedures and for the IVF procedure as well. So we are doing all testing that we can to do before the IVF procedure, just to exclude our negative attempt. Therefore, we have such high percentage of success rates because we are using all testing in advance just to prevent the patient for negative attempt. What about DNA fragmentation? As you said that you have 4th negative attempt, so you have already experience of negative attempts, and you need to understand why your attempt is negative before you will do the next one. I think that DNA fragmentation, this is not so hard to do because this is the sperm sample and you will receive the information. Is it high percentage of damaged spermatozoa or not? What to do? Our andrologist uses different supplementations, vitamins, antioxidants to decrease the level of DNA fragmentation. And we see the results. For example, if you have, we saw that approximately 20% of normozoospermia, when we have the normal measurement of the sperm, those patients have increased DNA fragmentation. When we see it, when we have negative attempts, or we have no embryos for the transfer, and we just start to investigate deeper the husband, because we didn't did it because we had a normal spermogram and we have no indications for the DNA fragmentation. And in that case, we see if we have high DNA fragmentation and our andrologist works with a patient and decreases the level, then we have a good result even in blastulation rates and of course in success rates in pregnancy.
And thank you once again for this. Okay, and there are a few questions left, so we will be slowly finishing. There are like 4 or 5 questions. So let's get to the next one. I am 37, have one ovary after a borderline tumor on the other one, AMH 0.5, and have one failed IVF last November. Before moving the second attempt, what tests do you recommend?
Only IMH level, this is not enough information for me. The first question is, it was blastocyst stage embryo transfer or it was day 3 embryo transfer? Because, for example, in our clinic, we don't provide day 3 embryo transfer. It is very, very rare cases because day 3, thank you. So we don't provide with the day 3 embryo transfers. Why? Because we understand that we don't know what we are transferring. Maybe a few years ago, there was a mind that it's better to transfer the embryo earlier to the uterus, because the uterus, this is more natural condition for the embryo, and more likely they will have that they will have mother condition, uterus condition. It will be easier for them to implant. But nowadays we understand that the pH and the different ingredients in the uterus are different between the uteral tube. And on day 3, the embryo is not in the uterus. On day 3, in our natural cycle, embryo is in the uterus tube. So nowadays, doctor says that if we will transfer day 3 embryo not to the tube but to the uterus, and we will receive the pregnancy, this is like survivals, because they dropped into not good conditions for the embryo inside the uterus. Therefore, we are cultivating the embryos up to day 5, and we understand that we have blastocyst stage, and we have good or not good embryo for the embryo transfer, and then we can predict some chances for the pregnancy. In very, very rare cases, when we have, for example, patients from abroad who have only one embryo and the embryo is cryopreserved on day 3, we have very less chances that it will survive up to day 5 in our conditions. Then, of course, we transfer them on day 5. But in case we have our cultivation, we don't use day 3 embryo transfer. Also, the quality of the embryos. For example, on day 3, it can be 5-cell embryo, 8-cell embryo, 7-cell embryo. The quality of the embryo also is a predictor of our chances. If we have on day 3 good morphological embryos, then we have higher chances for success. If not, then we understand that maybe the reason is in the embryos. Also, we can't exclude the uterus. I don't know which investigations were performed to you, and if you know that your uterus is ready enough for the second attempt. So did you have, maybe you have any myomas, maybe you have polyps inside, maybe you have adenomyosis, maybe you have chronic inflammatory process inside. So we need to have the answers on that questions before you will have the negative attempt. Second attempt, sorry.
Okay, excellent. And there another one, no test on uterus.
So it's better for sure. For me, it's better to have egg banking. This means that you will do several stimulations, not to waste the time. Accumulate the embryos, then do testing for the uterus, and then do embryo transfer when you understand that you excluded problems with the uterus.
And excellent. Thank you so much. And there's a thank you, of course, from the patient as well. I believe that helped. And of course, I just want to mention that we will be slowly finishing. But if you would have any questions left, I just want to mention that you can always send your questions using this link I have just sent to you, and that way you'll be able to get in touch with Intersono team and of course Dr. Roksolana. I'm sure they will be happy to assist. And well, let me go to the next question that we have. So do you have any guarantee live birth packages?
Yes, of course, we have not live birth packages. We have guaranteed pregnancy packages because the pregnancy, this is not only the question of the clinic and the team of the clinic. This is the mostly the responsibility of the patient, because you can have some problems with your health or some different conditions that can influence on the pregnancy progress, because this is 9 months. We have so packages for the surrogacy program. When we understand that we are transferring the embryo to the surrogate mother and she is under our supervision, and we understand that she is totally healthy, and we understand which risk we have, and we can guarantee the live birth. In case of patient programs and embryo transfer to the patients, we have the guarantee program, but only for the pregnancy. This means that we guarantee that you will be pregnant. This means that you will have ultrasound scanning and heartbeat on the ultrasound scan.
All right, perfect. Thank you so much. And then there's actually a follow-up from the patient. So with donor and surrogate live birth package?
Yes, with the surrogate package, we have and donor program and your own oocyte. We have a lot of variants.
Okay, Okay, thank you so much. And let me have a look. There is another one here. What supporting paperwork would you need if I send over embryos?
First of all, our coordinator will contact with your clinic, and we need the testing for hepatitis B, C, HIV, and syphilis. These for testing we need from your clinic on the day of embryo creation. I'm sure you did it at the clinic. And your permission that you allow us to take the embryos and to take them to the clinic. Our clinic has our own courier service. This means that our medical courier will take a duar and will go to the clinic where you store your embryo, take the embryos and ship them to our clinic. This is specially trained people, so they understand that they don't undergo X-raying, they don't leave the duar in the bagage, they are taking the duar to the cabin crew. They understand how to carry out and how handle this so tiny and so delicate material.
All right, thank you so much once again for that explanation. Okay, let me have a look. There's a follow-up one more time. So let me just go through this as this is regarding the same question. No, these infectious diseases were not done because I would have been the recipient for this sperm sample, but we have from other clinics infectious diseases test results. Yeah.
It doesn't matter from which clinic you have the results. I am talking about the time frame of the results. We need to have the negative results in time that the embryos were created. For example, they were created 2 years ago in November. So we need to have the testing 3 months prior to November that show that you have no these diseases.
All right. Thank you for clarification. Okay, I'm just checking. Okay, there's a follow-up. That's why I wanted to make sure. So no different time frame completely. Closest time frame was 7 months before.
I need to check because in accordance to our legislation, we need to have 3 months frame of testing on the moment of embryo creation. If you will leave to Caroline your contact or you will just email me, in that case, I will just check it and give you feedback.
Yes, excellent. Of course, you can always email me as well, caroline@ivfmedia.org. And I will just, in a minute, I will just simply provide you that email. And you can, of course, I will be happy to forward this. Okay. And I believe this will be our last question for today as we need to finish, as we are having another event later on. But I just want to ensure you that, of course, all the rest of the questions that haven't been answered, we will forward this to Dr. Roksolana and her team, and I am sure they will get back to you. Okay?
Of course. Of course.
Perfect. Thank you. So the question is right here. If in age 44, if the embryos are genetically tested and they are normal, what is the success rate? Is it equal to donor egg success rate, or again, age is influence on the success rate?
If we have embryos tested and they are healthy, so you have the same success rate as with the donor eggs, because our uterus is ready to implant at age 44, 54, and so on. If we have the good morphological and genetic healthy embryo, we have the same success rate as the embryo of young woman.
And perfect. Thank you so much again for answering that question. Well, thank you to all of you for joining us tonight, for staying and for listening, and of course for your questions. I am sure it has been quite helpful for you. And of course, well, Dr. Roksolana, you have been excellent with answering all the questions and of course with all the details you have provided. Very interesting, lots of information. So huge thank you for today. And I just want you to see that there are some comments ready. Thank you so much for very informative and presentation. It was excellent, very knowledgeable.
Thank you so much, Carolina, for advertising me and for opportunity to have the conversation with the patient in such a period, because we understand that nowadays we are stressed with that COVID virus and we don't know what to do. I just want to ask our patients not to stop in their willing to be a mother, and just make a little steps in front of their dream and just do it. Thank you so much for the
Excellent. Thank you.
questions. For the questions. Thank you.
Excellent. Thank you so much. As you can see, there are more thank yous coming your way as well. So it's always good to have you with us, actually. So I hope we can simply repeat that. And as you can see, there are plenty of questions. Don't worry, I will send them over to the team. And I just want to mention this has been recorded. So again, you will have a chance to watch this again. And I can only encourage you to subscribe to our YouTube channel. That way you will be notified when the video is uploaded. And also, as you know, we will start our next even IVF webinar at 8 p.m. UK time. So very, very soon. So I just need to go and check the connection with another presenter. So I hope you can join us as well. Dr. Roksolana, thank you so much once again.
Thank
It has
you.
been a pleasure. Have a lovely evening, everyone, as well. Thank you.
Thank you. The
And
same
bye.
to you. Bye
Thank
bye.
you. Bye.